Great. So you guys, I have to say, no current past relationships related to this learning activity. Received no speaker's fee for coming here today to talk to you guys. No in-kind financial support for any commercial or other organization. So I'm actually really super excited to be here to talk to you guys today about this non-prescription naloxone. And interestingly enough, I've been in front of some of you maybe twice now in the last few months, which isn't something I think comes around very often, to see 2 schedule changes on the same medication within less than half a year. So I'm hoping that today is really 2 points that I think I want to hit most home on for you guys today. And one is to understand why we've ended up in the situation, why we're dealing with 2 scheduled changes now to a completely unscheduled medication, and to learn how and emphasize the point of education as we move towards this being available absolutely anywhere, essentially, it could be, and to everybody. So those are the 2, and we'll talk a little bit about the sort of supplies and stuff needed for you guys to get that done. So just to get a little bit of understanding for myself, how many of you, say in the last few months, have sold naloxone? Some? Great, so some in the room? No, oh, lots, no, okay, that's good to know. I don't know if, am I allowed to like not use this, but can I just get a bit of show of hands? For those of you that have, I was interested to know, was it a loved one or a family member that came? Family members? Okay, interesting. That was something that I sort of wondered afterwards. And how many of you guys attended the training sessions back in May, whether in Kamloops or elsewhere? Good handful, yeah, some? Okay. Oh, no, 100% of you didn't come? Oh. That's okay. Okay, so I'm going to sort of carry on with this. I feel like I'm in a room full of pharmacists, so I probably don't need to actually touch on this a lot, but I just do want to highlight a few key points, and particularly in the context of educating as we talk about this as being one of the really important pieces of moving this forward. So it's an opiate antagonist medication that's been in clinical use for over 40 years. And also in lay public use since the 1990s. So we've had a lot of adoption, and for quite a lengthy period of time, of this being used in the context of being provided to people to intervene when drug overdoses are happening and save a life. And the 2 sort of key pieces that come along with knowing about this medication and passing it along to others is that it's not, it doesn't destroy the opioids when it's used. So when you're talking to your patients and when you're passing this information along, that's incredibly important for people to know, because we need them to understand that just because this has been administered, this person has come back, they're breathing again, they're not necessarily out of the dark. So that's one really key point. And the other is the half-life, that they're not only are they not out of the dark, they're only not out of the dark for about 30 to 90 minutes. So that's really important piece with the naloxone. So yesterday, I understand that the college's board has made this now an unscheduled medication, as I sort of alluded to, in an effort to move ahead what didn't really work with the change to Schedule 2 in May. So now we're moving to making this even more widely accessible and widely available, which is something that we understand is, you know, the risk here, the benefit is going to far outweigh any risk that might be associated with making this available to everybody at any time, even on the slight chances that they might get their hands on it without the education that we really strongly encourage you guys to be focused on. So that training component still we want to offer to them, call 911, rescue breathing, the little particulars as it goes along with the naloxone itself, important, but still better just to have it in the hands of people who might need to use it. It's a safe medication. It can't be abused. It doesn't work. It has no pharmacological effects in the absence of opiates. All it's doing in those really important moments is just simply restoring breathing. And that's huge. It's huge right now in the context of the public health emergency, which I'm going to talk a little bit about. Again, it's been used in Canada for over 40 years. And there's also evidence to suggest that it doesn't increase risk-taking behavior. So although it's important to still have those conversations with any patients that you're interacting with, it's good to know that because we're providing this, and now on an incredibly wide scale, it's not encouraging people to be more risky or take more of their drug because they have some underlying sense of confidence. So knowing that a lot of what's happened in the last few months has been as a result of what's been driving the public health crisis, just to even be announced as an emergency provincially, I wanted to take it back a little bit to recognize that these changes are not necessarily just reactive to that situation that's currently occurring, but that we've known for a long time that lay public accessibility and availability and an opportunity for people who are likely to witness an overdose, that this needed to happen anyways. So we know that if you're somebody who might see somebody overdose, you're poised and positioned to be able to recognize and respond in a meaningful way that can essentially save somebody's life or interrupt the harms associated with overdose. So provincially in 2012, for those of you that don't know, BC CDC launched a program that was able to be picked up in communities, and it's become incredibly widespread and recognized now. During that time, since 2012, we've seen 12,000 people throughout the province educated and taught how to recognize an overdose, how to respond to an overdose, including the administration of naloxone. And over 800 overdoses have actually been reported using the reporting sheets that the BC CDC collects. So that's probably way, way, way under what's actually happening in our communities, but it's still, that's about 200 people a year over the last 4 that have actually been able to use these kits. So the training for the public, also really, really important. So not only to users that have been able to actually intervene with their friends or somebody that they love, but also just building that awareness that over the past 4 years, I think has been really important to bring us to a point where we're at now with this program. I've never really seen a harm reduction intervention like this be so commonly understood and brought into the mainstream, which really helps us to sort of break down some of those stigmatizing ideas around who might need naloxone. And so why? Again, this really brings back to us today that although we know we needed to get here, we know we needed to increase the availability, but how did we get to this point of crisis? So we sort of have a twofold situation going on. We know that opiates are heavily prescribed in this country, so very, very common. And the fatalities, although from the context of the provincial health, public health emergency, have been sort of focused on the illicit drug deaths and the involvement of fentanyl, climbing from 5% to over 60% over the last 4 years being involved, that prescription drug deaths are also playing a part in what's going on here. And so you as pharmacists, are poised to have this opportunity to recognize this and use it as another flag or indicator that it might be a good talking point with some of your clients to get them involved, to get the conversation rolling on whether or not they might need a naloxone kit. We know that for illicit and licit drug overdose deaths and fatalities that a lot of times, the majority of times, polypharmacy, more than one prescription drug has been involved or implicated in the overdose. And then this picture, I feel like, has been fairly public in the media. This is the sort of sliding scale and increasing the tracking of the overdose fatalities that we've seen over the last few years in the illicit drug overdose deaths. And the crisis that we're in now has brought us to a point where people are dying every day, 2 people a day from these illicit drug fatalities. It's become the leading cause of accidental death, surpassing motor vehicle accidents, which is alarming and frightening. And frightening in the sense that it's not just one group of people, but all people who are taking drugs are truly at risk. Why else is it needed? So 3/4 of the time, people who are overdosing are in the presence of somebody else. And I think this is going to tie in nicely when I talk a little bit about what I see your role is with family and friends. But overwhelmingly we know now that training lay people to intervene in those situations, giving them the opportunity, the confidence to know that they can respond while waiting for ambulance, while waiting for firemen, particularly in rural, remote communities or denser urban centers where we're waiting for long periods of time for those trained medical staff to come. We can support our patients to know that they can make a difference. That timely restoration, that moment where somebody is struggling to breathe, we can now ensure that there's less opportunity for that to happen. So pharmacies, providing the patient education and training, incredibly important. Again, I'm going to hit on that point. Identifying the patients that may benefit from naloxone, and this I think is a really interesting one from my position. And so some of you have had the opportunity to sell the naloxone, some of you haven't. And I think what I'd like to encourage you today and what I'd like to put back on you is to when you leave here, to hopefully, instead of waiting for people to come to you and say, yeah, I want a naloxone kit, it's become more widely available, or waiting until somebody comes into your care and you kind of get that little flag that goes, oh, this person might kind of be at risk, I think I'm gonna talk to them about overdose. But even going so far as to actually put yourself out there as a proactive partner, use some of the resources that I'm going to show you later today, put them up in your pharmacy, talk about it and view it as a way to get people talking and know that you are an ally in fighting what is truly a horrid crisis that we're in. So I'd like to encourage you to be a little bit proactive and go out there and do that. And then, suggesting the naloxone and the supplies, which I think we'll cover in a little bit. So who would typically be flagged as somebody needing naloxone? And the provincial program has really sort of had an opportunity to flood the market and support these individuals. But I think in your guys' role, there's another opportunity for these particular demographics that may not themselves associate with being at risk. So somebody who might be on high opioid prescription that is responsible with their drug use, but still needing, still at risk. Anybody entering, tapering, starting methadone, Suboxone, other opioid antagonist therapies. Any opiate prescription where we have the comorbidities, pardon me, not comorbidities, the sort of breathing problems, kidney, liver disease, concurrent use of alcohol, benzodiazepines, those types of things, or some antidepressants as well. Anybody using illicit opiates, and I would actually probably change that now to anybody using illicit drugs. If you have somebody on your patient load who you know is using varying substances, I think it's important to have this conversation because we've seen that this is not limited to just illicit opiates. We've seen this overdose crisis fall into other categories such as ecstasy and cocaine and crack cocaine. And so another point not to limit it just to opiates. As well as, so these last two I think are really important, reduced abstinence, reduced tolerance as a result of abstinence. Sometimes people don't recognize how quickly their tolerance levels can change. So, if you have somebody who's on regular methadone, they miss 2 days, it's a good opportunity to start that conversation around, what happened, how come you missed it, can I offer you a naloxone kit, just any opportunity you have to sort of help them understand a little bit more about the risks that are involved. And then rural and remote areas. This is another place, and myself in the role that I do supporting the region of the Interior Health, we have a lot of rural and remote communities where, although we may have access to take-home naloxone programs from the provincial aspect, a lot of those access points have minimal times that they're available. So they might not have an emergency department room. Their public health department might only be open 1 to 2 days a week, but the pharmacy is there 7 days a week. So there is opportunity, and I think a key importance in recognizing the role that you all have to play in some of those sort of specialized areas. So who might you get? So if the provincial program is sort of covering, your people who are using drugs and those that are typically identified or thought to be at risk of an overdose, who might be walking into your pharmacy to ask for a kit? Well, certainly while it's while it's not on the formulary and there's still a charge to it, it's going to be a different group of people probably. So one is going to be people who just want to know. They want to be able to recognize, they want to be able to respond. It's all over the news, they're really interested. Maybe they run an agency, social housing or something like that, and they're experiencing overdoses. They want to make sure that their staff are equipped. So those might be people that are coming to you for education and information. And the second one is family and friends. And this is one that I think is really important. So provincially, we've got this program, it's running well, it's doing good work, and it's been directed towards people who are using opiates, so people who are using drugs and sort of are identified as at risk. And on the other side, we have this whole group of people, moms and dads and loved ones and friends who know somebody who's struggling. And they want to be able to be there. They have their son that comes home at night after using, and they want to be able to make sure they save a life. They have the opportunity to save his life or her life. And you guys, right now, with the access limited through the provincial program, parents and families and loved ones can go into a pharmacy and say, I don't know what else to do. I want to be able to know that in those moments, I have the right skills, the right knowledge to be able to save this person's life. So this is sort of something that I spoke about in May, and although it's not essentially really applicable in the context of an unscheduled medication, anybody can have it, I just wanted to touch on particularly the top 2 points in the context of maybe just understanding a little bit why we wouldn't want any limitations, or making sure that we know, just not to inadvertently put a limitation or a barrier on access. So age, we get this question a lot, like what if a 14-year-old comes in and says, I want a naloxone kit? So my harm reduction view really tells me, that's great. If that 14-year-old or 15-year-old is using drugs and they're walked into your pharmacy to say, I want a naloxone kit, at least I know that they've got some idea about the risk that's involved. And so at the end of the day, without that naloxone kit, their risk of overdose and their, the opportunity for education may pass, right? So that's, I think, a really important recognition. And on the flip side, they may be the loved one. They may have the parent who's using, they may be preparing themselves to respond in a situation like that. And then quantity. Interestingly enough, so certainly if it's a social housing or something like that, like I mentioned, they may want bigger quantity. They may not want to come back to you 2, 3, 4 times a month to pick up single doses if they're having people overdose on a regular basis. And certainly if we see this come onto the formulary where it's accessible and it's free, people who are using drugs regularly and responding to overdoses amongst their peer group often have to respond simultaneously. So quantity is important. So, I may be in a space where this person overdoses and I only have my 3 vials because that's sort of what comes with the kits usually. And at the same time that I'm responding here, my other friend over here is now overdosing. So there is some background and some reasoning behind why people may want 10 or 15 doses at a time. They may stockpile, and so just wanted to provide a little extra context for you guys there. So, training checklist that college has developed in partnership with BC CDC and Ministry of Health some really fantastic resources. And there's lots out there through the province, but there's 2 in particular that I think are really valuable for you guys. So this training checklist sort of offers the step-by-step reminder of what you might want to go with when you're talking about somebody, right from recognizing what an overdose actually looks like and helping somebody know the sort of different, sometimes very subtle symptoms of an overdose, to what puts you at risk. What is it that you're doing or somebody else might be doing that could increase their likelihood of overdosing, all the way over to the actual response, including 911 and the administration of rescue breathing. So it's important to point out and not to sort of underemphasize the rescue breathing piece and to focus on that in your education component as well. So naloxone is one amazing intervention, but it works better in combination with rescue breathing. In the patient education handout, I have to admit, this is one of my favorite resources in terms of giving to patients because it's so simple. So you've got what is naloxone, you're going to respond, or you're going to recognize the overdose, respond to it, and then you've got the 2 pictographs there in terms of the ampule and the hand. I love this resource. And this is also really handy because now you're in a situation you want to provide the education, but somebody comes into your space and they say, I really want 10 vials of naloxone and I don't want you to talk to me. Don't look at me, don't talk to me, just give it to me, I want to go. And, oh, well, it's, I'm going to give it to you. If you give it along with this, it has it there. So in that moment, even if you didn't have any training, but you knew you just wanted it in case it ever came up in front of you, it's basically going to be able to walk you through. So it's a fantastic resource that I encourage you to share and give out every time you're selling. And also a good one, and to go back to that challenge, to post up and just have visible, to create that conversation, to show that partnership and sort of allying to fight what's going on right now. So approved formulations, when I spoke to you guys in May, injectable solution only, ampules 0.4 milligram per mil, or the vials. In the last very recent little bit, there's been the addition of nasal sprays. In the sort of context of an interim order from Health Canada, it's been able to be brought in. And I think my understanding is that it's primarily going to be used for enforcement and corrections and other sort of areas that would be unlikely to want to be drawing up medication or actually administering intramuscular medication to a potential patient. And I understand that on the college's website, there will be a little bit more information if you guys are interested in sort of reviewing how you might want to be involved in bringing it in. And so there's a website and an email address that you guys can take a look at as well. So suggested dosing. So you're going to get involved, you're going to potentially sell this. We really recommend that you don't, that you offer minimum 2 doses. So oftentimes, and certainly over my 4 years of being involved in this program, directly teaching people, and now sort of at a coordination level, all the time I hear that 2 to 3 doses is sort of your average number that it takes for somebody in a lay setting to bring a patient around. So I want to encourage that. It may be that if you have people looking for multi-doses from agencies or to sort of amp up their first aid kits, it might be that the vials are a better option. So those are sort of the 2. Needles, 3 mil, sort of standard IM intramuscular needles, 25 gauge, 1 inch. The BC CDC program has always gone with the retractable needle, not necessarily a requirement, but certainly from a sort of safety standpoint, we don't need to worry about recapping. We don't need to worry about safety of first responders coming in afterwards. And the only thing I would point out there is that if you do go with this, when it comes to the education point, make a note to yourself not to forget to demonstrate that. At the very least, tell your patients that it will happen, because I've had a number of people come back over the years and say, nobody told me that that would happen, and I administered the naloxone, it went into his butt, the needle was gone, and they panicked, and they thought that they'd lost it inside. And so you're already sort of dealing with a sort of high adrenaline situation, especially when it might be your first time. It's the last thing you want to worry about is that you've now lost a big, long, sharp needle in somebody's body. So that would be sort of our suggested bundle. With the one extra addition of the plastic ampule breaker, again, I hear a lot of stories of people where it just sort of crumbles in their hand and they panic, there's extra strength because of all the adrenaline. So as many needles to match as many doses that you've decided to give, and bottle to put them all into. This is the photo of the BC CDC kit as it comes. So the extra little additions that wouldn't necessarily be the sort of core requirement, needles and naloxone, would be the gloves, the CPR face shield, which you can get in all sorts of different shapes or sizes if you wanted to give that out, as well as some alcohol swabs. So how many of you actually have seen some of the resources and or even the training webinar on the website? Some? Lots? Good. Yeah, that's great. Awesome. So all of those resources and more, there's a webinar, there's a PowerPoint up there, there's ampule and vial versions available for the patient education handout, can all be found on the website. Extra practice support questions can go to the college and or the DPIC line. More references on the Naloxone website.